I am C. Virginia Fields, former Manhattan Borough President and current President CEO of the National Black Leadership Commission on Health, formerly known as the National Black Leadership Commission on AIDS. And in 2019, after a 2.5-year rebranding process, after 32 years of advocating for African Americans to address and become more educated about HIV, the organization underwent a rebranding process. Because our work was inclusive of HIV and hepatitis C, but we understood that it was broader. And we understood the intersectionality between HIV, AIDS, and other diseases that disproportionately impact Black African Americans. So in 2019, just before the pandemic hit, the board approved a name change and thus Black Health, the National Black Leadership Commission on Health. We have a new mission, which is to champion promotion of health and prevention of diseases to reduce disparities and achieve equity within the Black community. And our vision is to promote the health and wellness of Black communities through education, advocacy, and policy. This was a major development as an evolution, but here we are, and we are very pleased to be able to continue to do the work for equity and elimination of disparities through education, policy, and advocacy. And today, we will be talking about where we are with one of our 8 major diseases, and that is cardiovascular disease. We will discuss cardiovascular health outcomes in the Black community, because based on data and some statistics, which we will be sharing later in the show, and I am pleased to be joined virtually for this discussion today, Dr. David Smith. And Dr. David Smith is a preventative cardiologist, clinical trials investigator, and clinical professor. Currently, he is practicing at Premier Cardiovascular Care and Wellness, and he is one of the most highly trained cardiologists in North Carolina. And see, we're national, so we bring in people from North Carolina and around the country. And from his combined clinical and basic scientific fellowships at Yale, blended with his epidemiology training at Columbia University's Millman School of Public Health, Dr. Smith brings a unique experience in integrated, holistic, evidence-based translational cardiology medicine to Charlotte and surrounding areas. And I think I messed up on that last word, but we'll take care of that too. So before we begin, first of all, Dr. Smith, let me welcome you to the show and ask, how's the weather down there in North Carolina?
It's crazy that it's cold, right? It's like 70 degrees on Christmas, and I'm cold today. 0 cents. I can't figure it out.
And that is exactly what we're experiencing here in New York City. And I mean, people are coming down with cold, with the flu, and maybe some other ailments, but it's up one day, down one day. It's pretty cold here today, but the sun is shining. But we are here, and we know that generally February has become to be known as Heart Disease Month. But we know within the Black community, our community is at risk of these diseases and these problems 365 days a year. Based on some of the information and the data that we often look at, it states that Black Americans are 30% more likely to die from heart disease than white Americans. And that, of course, some of the contributing factors that also disproportionately impact Black African Americans: diabetes and hypertension. And we've talked a lot on this show about how so many said that they were surprised during the height of COVID that so many Blacks were not only acquiring the disease, but also the mortality rates were so high. And our response to that continues to be, the data is irrefutable. It has been known a long time that Blacks disproportionately impacted by diseases that made us more vulnerable to COVID and other health issues than any other group. So your being here today is excited, and I'm glad to hear about the work that you're doing. And I'm actually going to decrease so that you can increase, and tell us a little about yourself. How did you get started in this field, and what some of the issues are that you're facing in your work? So welcome, Dr. Smith.
Thank you. Thank you again. Thank you again. So starting out how I started in this field, that's the funny part. You know, I'm the first generation Jamaican here in America. And, you know, it was pretty funny. Our background was pretty disadvantaged, obviously getting here. So when I was young and I was able to go to a doctor, I had a pediatrician. I just loved the way his hair looked, and I wanted my hair to be like that. So I said, you know what, I'm going to be a doctor one day, 6 years old. Had no clue what it meant. Didn't know that I had to get, you know, top grades or anything like that, but I got jealous in school, and, you know, somehow that propelled me to honors classes and then on to UConn, where I majored in physiology and neurobiology with a concentration in molecular and cellular biology, just because I thought it sounded great. Got me into medical school at Robert Wood Johnson, did internal medicine at Yale. Then I stayed on at Yale for my research fellowship, as you mentioned. And then I stayed on again for a cardiology fellowship, and was lucky enough to be appointed as instructor of medicine, and then promoted to clinical assistant professor. So it's not the tenured track, but I'm there to teach.
Now, you say you're the first generation to make it in America. Where were you born?
So it's so funny. I'm the last of the 6 kids. So my parents came here and had me, and then went back out to Jamaica, and then decided we're going to come back here to America. I feel cheated. I wish I grew up in Jamaica.
Well, you can now go to the movie and enjoy all this reggae music for Bob Marley's new film that's out there. And I'm excited. I'm going to go and see it this weekend. I love reggae music, though. Well, and the fact that, you know, you said something else, that at the age of 6, whether it was like in the way your pediatrician haircut was,
yeah,
or some other factors that inspired you. One of the things that I don't think we see enough today is those exposures to persons who can inspire them. So I was intrigued to hear you say that. So let me ask you a couple of questions with respect to the work in terms of what we're looking at today. What would you say are 2 main factors of heart disease with respect to diabetes and hypertension, which just still disproportionately impact Black Americans? What are some of the effective methods, I guess the question should be, in educating the community to reduce these risks? Because we see such high rates in our community and the association with heart disease.
Excellent. I hopefully not to sound too crass or anything, but what I would say is the best interventions are the ones we're not doing, right? You know, getting on TV or hearing a doctor saying, hey, you know, control your sugar, control your diabetes, control your blood pressure, those kind of things, they don't work well. At least not for most of the people I know, not for most of my patients, actually. So in my practice, it turns out what works better is for unrushed visits with the patients, with they'll come in and we'll talk about background, let down all the barriers and just kind of get it out, which then leads to the second thing, which is direct education, right? Seeing this on commercials, cartoons, or having people just talk about it in general, it's like, oh yeah, hey, fine, yeah, But once you start talking directly and personalizing it, things get better. That's actually a whole new movement in medicine now. It's personalized medicine, right? We know that people born in America are not going to have the same outcomes as those in Uganda, which is not going to be the same as those from Canada, and on and on and on. But even though you're in America, there are just so many differences, right? So short answer is, if there's one main intervention that I think works the best, is direct one-on-one education, communication, dialogue, not like the overbearing doctor or someone else, directly with people one-on-one. Community events work. We've done those as well.
Yeah. Well, how do we kind of look at that with respect to how healthcare is paid for? And you go in for 15 minutes, or you go in for 10 minutes, and a box is checked, and you see a bill from the doctor that they did all of this, and they didn't do it in that little 10 minutes or 5 minutes that they might have talked with you. So how do we kind of square that off with the payment based on time that doctors kind of allocate to spend with the patient to do that one-on-one? Because I agree with you, that one-on-one, and I feel very fortunate that most of my doctors I get that with, partly because I insist. So but how do we kind of square this away with the payment?
Yeah, and the answer is easy to me, but the actual application, practically getting it done, is extremely tough in America, right? Because to your point, you only have a few minutes to talk to people, and that's because of the system. You have to hurry up and get the person in. You have to see X amount of patients a day to even keep the building up and running, to keep you showing up there. And then, so for example, 15-minute visit might be 2 or 3 minutes of me figuring out what's going on or reviewing my notes, coming in maybe 7, 8, 9, 10 minutes with you, depending on what's going on, because I have to hurry up, get out and complete your note, get the order so I can move on to someone else. So you're right, you're not going to have a lot of communication with the current system, right? We don't do, healthcare here, but how do you help it best? If we can have slower visits, if we can move to this model that a lot of other people are moving to, called concierge medicine, where docs or patients form a club. They just pay a certain amount every month and then sit down and talk to your doc as long as you want to. I have a partner in cardiology who goes in, he'll meet you for lunch. You'll go for a walk, we'll have lunch together and we'll talk. Other times, what I do, if you get a lot of other doctors who are like-minded, focused on community, we cross-train, we talk a lot. So our words have so much more impact. I can say more in 3 or 4 minutes than you're probably going to get in 3 or 4 visits at other practices. And then, community events, maybe we can all get together around churches. That always helps a lot. Finally, another group, for example, ABC, Association of Black Cardiologists. I've been a member of that since forever. They have a lot of advocacy groups, community groups. And because of who we are with the ABC, all the barriers are down. You get the top professors in the country, sitting down with you and just having conversations and those kind of things. In other words, we have to have this, we have to bridge the divide, get rid of the barriers, have straight one-on-one discussions as blatantly as you can, and somehow get away for this all to be subsidized or paid in some other way.
I love it. I love what you're saying, especially, the one-on-ones and being very purposeful and intentional in terms of the work. But one of the things I guess I would raise is that, for example, the population that Black health, we serve a lot, people with on the lower socioeconomic level, and many not really having access to doctors, even with the affordable health care and other assistance that might, and of course, in states where they don't even approve it, that's even more dramatic. But not being able to have access to resources, they're still pretty left out there. But I like what you're saying, and I agree that education is the key. And to the extent that we can do more of that in our communities and raise awareness and provide access, maybe we have at least a better chance than we seem to have now. What do you think?
A whole lot, definitely a better chance. And yeah, you're right, education and access. But to your point, it's not just the doc accessibility, not just the doctor accessibility talking to you. You're right. You have to have places you can go. You have to have situations you can go to. And it's funny, in our community, the stressors tend to be a lot different, right? We talk again amongst ourselves all the time about social determinants of health, and we keep talking about those kind of things, whatever they mean. But people don't really understand the impact of these barriers. So social determinants of health, just kind of to lay the foundation, it's really the non-clinical factors that are barriers for you getting the best outcome you can have health-wise, and me having the best time I can get, the most effective and efficient time I can get getting you the information. And some people say it accounts for 80% of the disease out there. Access is definitely one, but people have to remember that access is a whole lot more than physically I'm here, physically you're there. In our communities, we have a harder time getting out. One quick story, and I can go on forever about this, but I know we're limited on time, but I just wanted to talk about one quick story. I had a lady who came to me and, nothing was working well for her. I tried a bunch of medicines for her blood pressure. They weren't working. I tried to get her weight down because I also do cardiobariatrics as a preventive measure. I tried to reverse her diabetes by getting rid of her waistline. Women shouldn't really have waistlines above 38, generally speaking, if you want to get rid of diabetes. We can go on and on. But the thing is, nothing was working. And she came to me because all of her other doctors were saying, just gave up on her. They said, well, you're not following our medicines anyway. Go see someone else. Go get a second opinion. Well, turned out that a lot of times the question came down to, should she go to work or not? Should she try to earn the money? And if she earned the money, should she pay for this medication or pay her light bill? Right? These are real discussions, right? I've had her bring her family in, and it turned out that she sometimes couldn't pay for the gas to drive to see her other doctors. And so her other doctors are saying, oh, well, she's not serious about it. This is not an important issue for her. So in that one sentence alone, and one, message alone, we have, doctor bias towards the patient bias towards the doctor. They're not getting everything done. Lack of communication, patient can't get there. This particular patient, had a GED, but wasn't able to pay for or go to college. So now you have, educational and economic attainment. You then had the medications that are not working because of the job she had. She had insurance that couldn't pay for the top medications, and she had a different formulary. Again, I can go on and on and on. But access means a whole lot to a whole lot of people. And so when you say the word access to me, it really has to be broken down. It means much more than actually I think we as doctors recognize.
And I'm smiling because you just described so many of the problems that we run into as community-based organization, working with people on the ground in communities, understanding that they would love to do more. But if you're going to say, go out and exercise in your community, you don't even have parks. You don't have safe sidewalks. You don't have stores with good quality food in it. And it is, as one whose background is social work, and we were always, taught in social work about the hierarchy needs. Until you meet basic needs of an individual, they're not going to move up that chain to become more involved in the community and civically and politically and other things that we would like to see them do. So you're absolutely correct. And that takes me to the next question that I just wanted to raise with you. And that is about policy. You mentioned being a part of the Black Cardiologist organization and so forth. So could you speak a little about what some of the policy or how the group actually promotes policies to bring about changes in some of these areas that we are talking about, because it is non-clinical. It has to do with factors that impact people's lives daily which you so eloquently spoke about, just even in relation to one patient. And when you multiply the number of patients who fall into that same category, we began to see the picture. So talk a little about policy in terms of what role does policy play in what you would say improving cardiovascular health and addressing disparities in health outcomes within our community.
Yeah, no, definitely. No, I appreciate that. So yeah, the Association of Black Cardiologists even have their own advocacy group, but so does the ACC, American College of Cardiology, American Heart Association, National Medical Association. Pretty much all the big organizations do have an advocacy arm where community members can join, definitely. So yeah, we're talking about access, not only from the person being there, from you getting the information, from you getting all the resources to get the information, but some of the other things that we work on, or I should say the central thing that we work on with the ABC is to eliminate racial bias. And that means a lot to a lot of people. And honestly, to me, it's bi-directional, right? So if we're talking about we have to get the best care to people, it's interesting that between Hispanics, Asians, and Blacks, we make up over a third of the United States, yet none of us are able to see doctors who look just like us. And the purpose is not just to look like us to say, oh yeah, I have a Black doctor. No, but there are cultural, there are social similarities. There are ways that we can talk to each other, and there are connections and barriers and even heightened anxiety and stress that actually cut down when you're hanging out with people who talk to us, who know where we're coming from, who can actually relate a lot better. Some of the things in ABC, one of the things I think we did was one of our focus points is to eliminate, I guess, barriers to getting the doctors out there. Pipeline programs is something that we're working on. Miss Cook, I think she's your program director. She was in one of the pipeline programs at Yale. One of the things Yale started doing now, and it was when I was there, is kind of like the kids who come out of high school have no clue what it takes to get to medical school. We just say we want to be doctors, right? And so I had mentors through Yale who were Spanish, who were Black, who told me, hey, Dave, you need to major in this. You need to take this test. You need to go forward. So there are pipeline programs. That's one thing that will help dramatically. Clinical trials is another huge one. You guys have probably all seen on TV this drug. And yeah, I'm not mentioning names to say anything bad, but let's take the drug by Novartis, right? Entresto. Great drug, great medicine. They're saying, hey, this is the largest clinical trial ever, great for heart patients. The things that we're missing is that that trial was predominantly done in everywhere but America, right? It's an international trial published on data from 2009, 2014 out by the time you actually aggregated the information. And I think it was like 0.5% of them were Black, which out of 14,000, I don't know. It came out to 400 Blacks who were not in America, but yet Entresto is prescribed or suggested for us to take. So we're not represented in clinical trials. We don't know if the drug is going to work or not going to work. We don't have the people who are going to look like us, who are going to advocate for us, who are going to actually try to get us the medications as we would like to. And then you even look at the technologies. Once we're talking about patients from certain underserved or disadvantaged communities without the insurance, as I mentioned, they may not have the insurance plan that's going to cover the right kind of therapies they need, not just their best drugs, not just where you see on TV, everybody wants to lose weight and they're taking semaglutide, not that. But what about the people who can't get insulin and they're diabetic? We know diabetics are going to lose their legs, they're going to lose their eyes. You don't die of diabetes, you die of cardiovascular complications of diabetes. What about those who get heart failure, heart attacks, and then they say they can't breathe, they can't walk. They're just like, oh, I'm tired and I'm short of breath. No, it could be heart failure, but they're not going to get that checked out. They're not going to get that tested because they can't take time off of work. They can't get to the docs on time. The access is not there. And even when they are there, what if we do find that they have heart failure and they actually do have some sort of damage to their heart? Maybe they can benefit from something called a defibrillator. They're even more advanced now. We have the Rolls Royce of defibrillators. We have CRT. We have a bunch of other technologies that unfortunately they may not be able to get. I have a family member in Connecticut now who has bad disease and can't get this. So there's so many different things to do. So short answer to your question, get together in groups because, a fist is better, right, than individual fingers, right? We have to coalesce, we have to align, we have to get together, get with these groups, start talking, write letters to your local Congress, your local representatives, get together in advocacy groups, and then go to Congress themselves, write letters, let people know what we're doing. Write the insurance companies, let them know they need to cover more, because if a group of patients decided we're not going to buy your insurance policy unless you cover us, well, that speaks a lot more than one or two people writing a letter here and there. And I could go on. Somebody explained to me why there's in every Black community, why is there an alcohol? Why is there an ABC store? Why are there smoking shops? Why is everybody vaping? Why do you target those communities to put up those stores? Write your city, write those people, get regentrification, get those people out, move the housing, get different stores in. And when I talk about food, I want the right food. Don't let McDonald's and Burger King be the only ones that are near me. Why are the salad bars and all the better meals in the neighborhood across the tracks? So policy-wise, there are a lot of things that we can do. We can get attention to these issues, attention to where they need to be, and then attention to the final thing that really motivates people in America, which is the cost-benefit analysis. Right.
And you have covered it. And that is just so phenomenal in terms of what you have said. And that really speaks to our work also here at Black Health. So I certainly want to thank you for joining us today. Clearly, your expertise on cardiovascular health outcomes has certainly provided a new perspective, I know, for many of our new viewers. And only by lifting our collective voices to educate not only our loved ones, but the broader community, will we be able to see these kind of turnarounds. And I'm looking forward to our organization working closer with you as the work continues, because there is so much more to be done. So I just want to thank you on behalf of the National Black Leadership Commission on Health, Black Health, and to our viewers. For more information about Black Health, please visit our website at www.nblch.org. And you can look for us on Facebook, Instagram, LinkedIn, as well as YouTube. And I would say that the Manhattan Neighborhood Network that brings these programs to you is to really better inform you, our viewers, about these very important topics. And we ask that you please let your family, your friends, and your community know about these programs. And again, I am C. Virginia Fields, and I thank my guest, Dr. Smith, and I thank all of you for joining us, and hope you'll tune in next time for Health Action TV here on Manhattan Neighborhood Network. Thank you.